Hi guys, welcome back to the channel after the weekend. Hope you had a good weekend. So last week we have completed with actinic keratosis and we'll be starting the new skin premalignant and malignant lesion, that is keratoacanthoma. So let's start today's class, okay? Okay. Keratoacanthoma, clinical presentation and pathogenesis. They are tumorous skin lesions that bear a close relationship to well differentiated squamous cell carcinoma of skin. Okay, so they are a tumorous skin lesion. Okay, and they bear a close relationship to well differentiated squamous cell carcinoma of skin. It seems to arise from hair shaft epithelium, most often related to sun exposure, and it is most commonly found on the surface which are mostly exposed to sun. So जो फेस का पार्ट सन एक्सपोजर से ज़्यादा मतलब सन से ज़्यादा एक्सपोज है वो, then shoulder and the dorsum of hands. Now, isolated keratoacanthoma may emerge after a penetrating trauma even in the sites not exposed to sun, और कभी कभी दे इमर्ज आफ्टर अ पेनिट्रेटिंग ट्रॉमा, और ज़रूरी नहीं है वो साइट जहाँ पे इमर्ज हुआ है वो सन एक्सपोजर के लिए हो, मतलब सन एक्सपोज्ड वाले एरिया हो. नाउ oral cavity keratoacanthoma is not found, only very rare and not found, it seems to be. Okay, but lower lip keratoacanthoma emerging in paramidline lip pout are well known. Okay, now they classically emerge from a normal surface over 6 weeks, undergo a 6-week period of dormancy, and then undergo extrusion of its central keratin plug and involute into a dimpled scar over another 6 weeks. So in 40% of cases what happened, they emerge from a normal surface over 6 weeks, then 6-week period of dormancy में चले जाते हैं. उसके बाद वो एक्सट्रूशन करते हैं अपने सेंट्रल केराटिन प्लग का, and then they involute into dimple scar in another 6 weeks. This happened in 40% of cases, but in 60% of cases either involute only partially or remain in the same size or increase in size after the period of dormancy or quiescence. Now, fully developed keratoacanthoma is seen as elevated mass with a central crater of brown or black keratin. So this central crater of brown or black keratin and elevated mass is a characteristic feature of keratoacanthoma with rolled up margin. Okay, if there is rolled up margin, elevated mass and a central crater of brown or black keratin plug दिखते हैं और में भी, लेकिन अगर rolled up margin है और elevated mass है तो this is the characteristic of fully developed keratoacanthoma. The edge will be elevated and rolled in a sharp border with the adjacent skin, which will show 1 to 2 mm band of erythema. Okay. Now, it can arise at any stage, but adults with the history of sun exposure are most commonly affected. They are generally isolated lesions, but in two syndromes they appear in multiple lesions. First syndrome is Ferguson-Smith's type, which is found mainly in children, and the lesion number ranges from 5 to 20. तो 5 से 20 lesions दिखेंगे and almost always involute completely. And the another syndrome is Grybowski type. Okay, this is found mainly in adults. तो जो पहला वाला syndrome था Ferguson Smith type, that was found in children, and this Grybowski type are found in adults. Okay, इसमें जो लीशंस होंगे नंबर वो ओवर 100 होंगे और स्मॉल लीशंस होंगे, नॉट लार्ज, स्मॉल लीशन बट रेंजिंग ओवर 100 in numbers, and they are also found as a component in Torres syndrome. तो ये जो टाइप ऐसे होते हैं वो टॉरस सिंड्रोम में भी मिलते हैं. ओके, दैट्स ऑल फॉर टुडेज क्लास. विल बी कंटिन्यूइंग दिस इन द नेक्स्ट क्लास. टिल देन, लाइक, शेयर, सब्सक्राइब एंड कमेंट. बाय.